Good afternoon. So you just heard from two of our co-authors regarding some of the specific actions we implemented. Now I'm going to present on our COVID problem resolution at a systemic level and how we pivoted towards values to navigate the COVID crisis as a service organization in California. As I was preparing for this presentation, I was really present to thinking about a behavior analytic approach to large scale problem resolution or a definition of problems or a definition of leadership behavior analytically. And I did find a succinct definition on problem resolution offered by Turner and colleagues. And I found a wealth of information in a special issue of JOBN, where Keller and colleagues Dr. Biglin and Alavocius and colleagues offered great insight into leadership and company culture. And the introduction alone by Dr. Ramona Humanfar provided me with many thoughts on leadership and cultural change. Yet this was reading for this presentation and a newfound curiosity of what behavior analysts have to say about problem resolution. I did not know how valuable any of these things could have been. My graduate studies prepared me to approach all problems behavior analytically, and I've been convinced of the power of our science for a couple decades at this point. And I'm quite sure that this learning prepared me in a relative sense, yet I'll be 100% transparent that when COVID hit and a shelter in place dropped in on a Thursday night, March 12th, 2020, and immediately all the schools we worked with closed, and it appeared that all of our home-based services were coming to a screeching halt, I did not feel prepared. Now, 14 months later, I feel so fortunate to share with you how we pivoted as a team and traversed the initial and ongoing problem resolution throughout COVID-19. So let me begin by describing some key features of our organization. We are a group of clinicians working with various types of learners with developmental delays and behavioral challenges. Our group spans across California, and at this point we have 5 locations, and we have a team of 170 hardworking, children-loving research practitioners who work with 260 learners. At ABRITE, we provide behavior analytics services in the home and center with our insurance-funded services. We also provide educationally based services to school districts across several counties, and a brand new 2019-20, in the 2019-20 school year, we started our Passion Project that was a non-public school run behavior analytically, just in time for schools to close. So we have been working on our system for 14 years, and many of our employees has been with us since the beginning. Our employees operate within a larger context that needs to be shared to understand really kind of key aspects. They operate within verbally stated rules and values and years of practices and procedures wrapped around these values. For example, always putting team first. That shows up in team-led scheduling and team-led problem resolution. Our second value is towards children and the families we serve, and that comes from analyzing and maximizing outcomes at the individual child, but also ongoing evaluation of the outcomes we produce collectively over time. We also believe heavily in communication via staff meetings, weekly announcements, monthly newsletter, and sharing the whys behind our decisions whenever possible. We teach our supervisors to address all unworkability via conflict resolution training, and even when it's aversive or difficult to do so that they can have authentic and clear relationships. In addition, we believe in the practice of creation of possibilities and addressing any thwarted communication. We've replaced words with but as and. We practice ACT with our leadership by pivoting towards possibilities, and we don't focus on barriers. We operate daily with integrity that our word is only powerful when we show up 100% for our commitments, verbally stated or implicitly known, based on our responsibilities as leaders. All of this learning and many years of working together and actively problem solving instantly became essential. The threats of losing our team and 260 children going without medically necessary services and educational supports was heavy, and it was downright frightening. So we pivoted quickly towards values and decided to divide and attempt to conquer in order to navigate the largest and most daunting problem we had yet faced. The 2 founding directors of our company and a 3rd PhD and a CFO consult became leaders of our COVID response team. Within 3 days, there was a creation of a plan with position statements around 3 values and the core factors that would lead us. Team ABRITE was based on the position that we value our team and solidarity. Team access was based on the position that we value the learners we serve and their families. Team research was based on the belief in the necessity to continue to demonstrate continued effectiveness. So we created 3 teams and a doctorate level clinician to lead each team. And these 3 teams implemented an overall plan to take on the series of ever-changing problems that were coming at us. We moved to daily leadership meetings for our COVID response team in order to navigate the first of a series of problems. And this figure depicts our ongoing problem resolution at a systemic level. For us, the way we viewed this is new information came at us. We quickly had a directors meeting. In the directors meeting, each of the team leaders focused on their goal, and we were able to then problem solve. We were able to look at the individual choices, make a decision, implement new practices in accordance with that decision, and then get feedback from our team. Then very quickly, new information would come at us. So now I'll explain some of the details of each of our teams. Team ABRITE was led by me, and the goal was team safety and to navigate all CDC recommendations, OSHA regs, FFCRA, Department of Labor, and really to keep our employees safe. We believe that we fought hard for medical necessity, so it was essential to continue to provide services and really lean in for children and families. Some important aspects of Team ABRITE were weekly COVID and question and answer COVID meetings. They were fated to monthly check-ins. We offered voluntary opting out of our system. We had some limited layoffs. We did some pay reduction and increased workloads for a couple weeks at least. And we led through county health, basically recommendations. We attended weekly meetings with them to learn more and stay abreast of all of these changes. If we we came to position statements, for example, if RBTs were doing one-to-ones, then all needed to be able to be in person so that they felt supported, seen, and heard. We also tried to pivot towards possibility by creating a thing within our team called Bright Spots so that we could share data or we could share, child observations that moved us so that we could stay positive while we were really navigating difficult things. In addition, we were looking at, masks and how to find masks and, really in the very beginning, there was such limited access to everything. We were able to provide masks. We were able to provide care packages and things of that sort for our team. We started contact tracing almost immediately. We also traced COVID exposure, any symptoms by our team members, positive outcomes, as in they tested positive for COVID, and any transmissions. These were documented daily. We created behavioral contracting with our parents and our team on physical distancing and travel policies. We created new hiring and new scheduling procedures. And then we ended up towards the end, or more currently, creating a path towards vaccinations. The second team really was Dr. Frederick, and she led pivoting towards possibilities in the presence of the shelter and the potential closing of our school in order to ensure access. So persistent advocacy, problem resolution, and collaboration with our SELPA directors. There we have NPS and NPA services. So there had to be a creation of distance learning, Google Classroom parent packets, telehealth stations for RBT, and training curriculum was needed immediately. In addition, she had to navigate access to services for those in our home-based services or in our center-based services for telehealth. She created a telehealth model and a plan. We assisted with a plan to take on scheduling, planning across locations, so that even when we had decreased team members, we were able to remove the boundaries and be able to provide staff resources across locations. In addition, we were focused on access and we looked at empty offices and team members working remotely, parents needing assistance, and we created things like summer camps. So in addition to Team Access and Team ABRITE, Dr. Rogers also led team research. So there was a commitment to the examination of our outcomes at the individual, group, and systemic level, and also to take on socially significant problems. Dr. Rogers and Dr. Frederick then created a series of research studies to look at things like mask wearing, social distancing, self-health modules, and curriculum so that we could help learners acquire some of these skills and also, stay safe throughout COVID. In addition, they just presented on some of the system of supports that we created for our team. And there was also analyses of prerequisite skills assessments for some of our learners. And we also have an ongoing examination of gains achieved at in-person versus telepractice, BST to teach core prerequisite skills. We're also looking at relative gains within different groups of children, like those within our preschool program, or analyses of hours delivered to individual groups, and also larger scale analyses, such as parent and student supports and employee satisfaction and their self-reported confidence with the team. So I'm going to go through, we have a lot of results, but I'm going to go through them quite quickly. So when it came to Team ABRITE, there were limited layoffs in March and April of 2020, and a rebuilding began as early as May 1st, 2020. Yet we went very quickly from 175 employees down to 132. When the universities closed, our teams lost their housing essentially. So many team members had to move home. Since then, we've been rebuilding our team and we're 160 team members strong. In addition, we've really been focusing our efforts on vaccinations, OSHA regulations, keeping employees safe, and tracking data to speak to that level of safety. Within our system in the last year, there has not been one positive transmission, such that not a single team member got a child sick or a single child got a team member sick, despite some team members testing positive for COVID-19. Throughout all of this, we also tried to continue to check in with our team members, and we created 2 probes of employee surveys. So first, anonymous surveys revealed that 95% of our employees felt supported to very supported throughout the COVID crisis during our first probe in April of 2020. And in April of 2021, 99% reported feeling very supported. Whereas 96% of our surveyed employees in the first probe and 100% of employees in the second probe reported confidence with our leaders' ability to navigate the COVID crisis. So results for team access, really super important, but persistent advocacy, problem resolution, and collaboration really proved effective. All MPS students and MPA students continued to receive services. One-to-one sessions were offered for most families, and telehealth was created across all of our tiers and all of our different services for families. And we are now safely transitioning back to campus. This figure displays the cumulative number of BI hours delivered via telepractice across learners and school-funded programs. Month of service are along the x-axis, and number of hours are displayed on the y. As depicted, over 27,000 hours of BI level telepractice have been provided in the last 14 months, compared to 0 provided in February of 2021. And the other 156 months our organization has been providing services. We have never delivered our services via telehealth at the BI level. Working together with a strong team has led to positive outcomes. Every single family, student, and district has access to services, and we're transitioning back to face-to-face for those that were telehealth. Not for all, but we're transitioning. We've returned to our initial service levels, and we've learned many new skills. We've changed and rebuilt our team into a fast service delivery model with measurement. And we believe that was key because we did not get stuck in individualization that would produce delays or lack of action. Anecdotally, a few factors that may have contributed to our telehealth outcomes that we achieved might be related to the fact that we really focus on stimulus control procedures within ABRITE so that our team members do have balance. They're able to, have time to themselves every single night and weekend. We plan towards commitments and values to address monthly barriers, and we provide compassionate but clinician-led services. So there's a lot of rapport and buy-in and trust. And when we suggested pivoting to telehealth, our families trusted us. We also show up for our communities, and we practice creating what the community needs, not just focusing on a single level of service. And that might have created might have assisted in our overall success, relative success. So I've never been more present to the need for an analysis of culture. I personally am moved, touched, and inspired by our group. And they've shown up for each other, the directors of ABRITE and the children and families that we work with, despite, fears for their own health, fears for their job initially, I'm sure, and unprecedented uncertainty. I believe in an analysis of any single measure of satisfaction would likely fall short, as there were many days of unsatisfaction. And clearly, telehealth and the safety it affords is one such factor that really warrants continued examination because telehealth and the power of the group, the power of pivoting, the power of possibility, all of these things have never been more needed and potentially useful to minimize burnout for an already reported stressed field. And throughout our crisis, our senior clinicians demonstrated, their values to access to services by publishing twice so that we could share with other behavior analysts and assist in eliminating barriers. For us, this is an example of value-based living and a demonstration in our belief in access and continued advocacy. In addition, it is my belief that further examination of the system and the culture that we create as behavior analysts with the implementation of behavior analysis would prove invaluable. A Cantorian analysis of culture would look at the behaviors of the group that are sustained in the absence of contingencies present in the environment. Seems very warranted currently, when a simple analysis of contingencies could point to the advantages of unemployment at this point. It could point to the advantages of not leaving your home. Yet we owe it to our team really to define and isolate the practices of our team and our culture that is resulting. Speaking colloquially, we have not yet won the war, right? But we've showed up as a team and we won many battles. And we now have a momentum and an increased confidence to be able to come together with an awesome team that is really pivoting towards science. When COVID lifts, we hope to continue to evaluate the aspects of our actions that deemed effective and the practices that we are creating that's this supportive and positive culture so that we can share what we learned and tie this learning to the logician J.R. Cantor. Thank you for your time.